are we gonna do in a case of a snake bite? The first aid component. The mnemonic for that is very well known to us. That is first aid, do it right. What I mean by first aid, do it right is R would mean reassure the patient, as I explained to you, immobilize the patient, do not make the person walk. The person should always be carried, because if he will walk, the venom will spread faster in the body. So immobilization of the person has to be done. GS stands for go to the hospital, and T stands for tell the doctor of the systemic symptoms that might have occurred. Let's quickly revise. Right would mean one. R would mean reassure the patient, as I explained to you that nothing is going to happen. Majority of bites are going to be with non-venomous snakes. I would mean immobilization, carry the patient. GH is go to the hospital and then tell the doctor the systemic symptoms. And please remember, at the moment, the current concept is that there is no rule of any tourniquets. In earlier times, they recommended tourniquet. Even in Hindi movies, they show tourniquet being tied and lot of other things being done. None of them have been documented, because once the venom is injected into a bloodstream, it will anyway start causing manifestations in a person. So, cutting of the local area or electrocautery of that particular area, or letting that area bleed, is not gonna let the toxin escape, because it has already been injected into the bloodstream of the patient. No tourniquet, no cutting, no electrocautery is the current representation. And as I said, no walking. Obviously, immobilization of the patient is of paramount importance. This will also ensure the fact that the heart rate of the person will tend to remain, relatively lower as compared to that on walking, because the faster the heart will beat, the faster the circulation will flow, faster the venom will tend to flow in the body of the person. In the API protocol, they have also said, or have just mentioned one line regarding nitrogesic ointment. Nitrogesic would be local nitrate ointment that can be applied at the local part. Though the validity of this or the efficacy of this has not been proven, but still API textbook has mentioned nitrogesic or nitrate spray being applied locally at the site of the bite. Though there are no real clinical trials determining the efficacy of it, but still, since it is mentioned in the textbook, I just thought that it could be one of the choices in the question, which might say all are true about management of a snake bite. So obviously it is no of these aspects, and then nitrate application, which is again beginning with N. So just remember the fact that nitrate spray or nitrogesic ointment application is also recommended, though as such it has not been proven to have any great efficacy when it comes to clinical trials. So why a no tourniquet? One of the reasons for that could be development of pressure necrosis because of the tourniquet per se. You see, the snake bite itself will contribute to local swelling and a possible compartment syndrome. To add insult to the injury, if you tie a rope or a cloth around that area or a metal wire around that area and then tighten it, then the chances of compartment syndrome worsening will definitely increase. So pressure necrosis is on its way, and the person might even lose the limb and even might require an amputation. The second problem will be that suppose the tourniquet is in place, like a person from rural India, from Faridabad, Ghaziabad, peripherals, was brought into your tertiary care hospital, and he is having a tourniquet in the leg, above knee, below knee, wherever. What would you do? Obviously, if you cut the tourniquet, the escape of the toxin, the neurotoxin, will suddenly come into the venous circulation. So there could be sudden deterioration of a patient, including diaphragmatic paralysis in a person, or there could be sudden hypotension occurring in the patient because the toxin will contribute to vasodilation, histamine release. I don't want any of these to happen. So what will you do? You will apply a BP cuff proximal to the tourniquet and inflate it to a pressure almost equivalent to that of actually the tourniquet, and then you cut the tourniquet. You will deflate the BP cuff gradually in the patient. Let me say every 15 minutes you can gradually deflate, and by that time the anti-snake venom administration would have already started in the patient. So you will now be having anti-snake venom present in the circulation to neutralize the venom of the snake. So I repeat that again, no tourniquet. Why? Because on cutting of the tourniquet, two things can happen, and that has happened a couple of times, that the doctor had to cut the tourniquet anyway to relieve the local obstruction or the local swelling of the affected part to save the affected arm. And what happened was a development of diaphragmatic paralysis, because the neurotoxin can contribute to a respiratory arrest and apnea in the patient. Second, due to release of histamine, there could be a sudden onset hypotension, and to resuscitate a person like this who is had a snake bite at the moment and suddenly the BP will crash, so it becomes little difficult for you to manage the patient. So it's always a good idea to inflate a BP cuff proximal to the tourniquet and then gradually deflate the BP cuff in the patient. Person The first and the foremost step is to talk to the person in a calm, reassuring voice and take care of the pain component and the fear component. For pain, he recommends paracetamol and not any standard painkiller. I've already explained to you that if a tourniquet is in place, because cultural practices will ensure application of a tourniquet, apply a BP cuff above the level of the tourniquet, and once you cut the tourniquet, then you should gradually deflate the BP cuff in the person. This is basically to prevent sudden release of venom into the blood circulation, contributing to either a respiratory paralysis or a hypotension. The most important step on which you will always be asked in the exam is regarding polyvalent ASV, which does not work against a humped nose viper. The dose of anti-snake venin or ASV will be same for both children as well as for adults. That's again a MCQ statement because the snake will inject the same amount of venom in both a adult child or pregnant lady. I repeat my statement once again. Dose of ASV in child and pregnancy is same as that of adults because we need to neutralize the amount of toxin the snake has injected into the body, and a snake will not discriminate obviously between an adult and a child. It is 10 to 30 vials that are recommended, though there are studies from Kerala where they have used up to 50 vials in patients. MCQ wise, remember half-life of ASV is 90 hours, so there is no need for re-administration of the Indian ASV. The American ASV might have to be repeated after 48 hours, but in Indian ASV, because the half-life is very long, so we do not require a re-administration in the patient. Also remember, one vial can neutralize. That's again a MCQ statement. 6 milligram of Russell Viper venom. So we will have a look at the data once again. The door to needle time for myocardial infarction is 30 minutes. Here I am teaching you regarding a parameter which is called as bite to needle time. This should be kept under 4 hours. So there is no door to needle time. It is bite to needle time that I've highlighted before you as under 4 hours. So we will talk about indications of ASV in a person, and when you are giving ASV to a person, because anaphylactic shock can occur, so keep adrenaline ready. I mean, keep adrenaline in the syringe, ready for administration if anaphylactic shock will occur. And how would you know anaphylactic shock is occurring after administration of ASV? There would be stridor in a person, there would be cyanosis, there would be crashing of the blood pressure. So load adrenaline into the patient, and you should be ready in advance. Indications for ASV, I'll teach you six of them, out of which the first two I usually don't find people having a problem with. The one, the first point to be remembered is coagulopathy. The bleeding manifestation, you can remember it from the image I showed you. Person was having bleeding from gums, and then the bleeding became so extensive that he developed even a hypotension. So ASV is definitely warranted in this case. Point number two to be remembered is neurotoxicity. To remember neurotoxicity, I taught you about four P's in the patient, which would be ptosis, then would be paralysis of the jaw, pooling of secretions, and dyspnea developing in a patient due to paralysis of diaphragm. Now, in the casualty, when the case has come right now under pressure, you may have difficulty in remembering the four P's. So I'll try to simplify before you. That is one, ask the person to raise his neck. Like he is lying in the hospital bed, you have given a command, raise your neck. So if a person is having paralysis, then he may not be able to raise his neck. It's easy test to perform. And then another test you can perform is like ask him to count 1, 2, 3, 4 or ABCD or whatever. So single breath count. They will give you an idea regarding the severity of neurotoxicity that is present in an individual, and most people who are having a neurotoxicity will not be able to count properly or will not be able to raise their neck. So it's a very objective and a quick assessment that tells you the fact that the person has deteriorated and ASV is warranted right now. Then would be cardiovascular abnormalities in a person. The cardiovascular abnormalities can range from hypotension or development of tachyarrhythmias in a patient, which can range from ventricular tachycardia to ventricular fibrillation in a patient. The fourth indication for why ASV should be given is severe vomiting and abdominal pain. There can be two explanations for the vomiting and the abdominal pain component of the patient. I will say the more dangerous one first, retroperitoneal bleeding. To diagnose retroperitoneal bleeding, you will finally have to do a CT abdomen or a MRI abdomen, and they may not be available right now. So first give ASV to the patient straight away on clinical grounds because you are suspecting a retroperitoneal bleed, and secondly, he could be bleeding in his stomach. That that will irritate the stomach mucosa, so he can be puking again and again. Point number 5 and 6 are related to swelling. One is that the severity of the local swelling is so much, like this person was bitten on the hand or on the big toe of the foot, and the local swelling in the arm is more than half of the circumference of the arm or more than half of the circumference of the leg. You are having an extensively swollen leg or arm in a person, more than the routine the circumference. I mean, more than half of the total arm circumference or the leg circumference. It indicates ASV to be administered. Second is that the swelling has extended rapidly. That could be maybe after cutting of the tourniquet, a rapid extension of the swelling. This is rather a vague terminology, but he says rapid extension of the swelling above the level of the waist is an indication for administration of ASV in a patient. 1 and 2 are very straightforward, but it is 3, 4, 5, 6 that we will revise again. That is hemodynamic instability, retroperitoneal bleed presenting as abdominal pain, swelling in the arm, which is more than half of the circumference of the arm. The arm is swollen very big, or when you cut the tourniquet, there was a sudden increase in the swelling, which from the leg has extended up to the waist of the person. So these are the situations in which ASV is to be given immediately to the patient. Now, as I explained to you that anaphylactic shock can occur, so to prevent reaction to ASV, we usually give hydrocortisone 100 milligram along with chlorpheniramine maleate, that is Avil injection or antihistaminic drug to the patient. So hydrocortisone and H1 blockers should be administered immediately in all patients who are in the process of receiving a ASV to minimize the reaction. And if there is any indication of anaphylactic shock, then in those circumstances give IV adrenaline. I would like to draw your attention to the fact that normally in anaphylactic shock we give intramuscular. But in this case, let me say it's a viper bite, you're giving intramuscular, there could be local hematoma. And if the BP is very less, the intramuscular adrenaline may not be absorbed. So he says categorically that in a case of a ASV, if anaphylaxis is occurring in a person, you have to give IV adrenaline to the patient. This IV adrenaline would be given undiluted to the patient, that is 1 is to 1000. That is obviously risky because it can trigger tachyarrhythmias also. But that is why I was saying that giving ASV can also be a dicey situation. However, if anaphylactic shock will occur in a person, how would you pick up development of anaphylactic shock? Sudden crashing of BP in the patient with laryngeal edema, stridor, cyanosis, SpO2 falling in a person. Then you have to give intravenous adrenaline. Mark my words here, routinely in anaphylactic shock, we always give intramuscular adrenaline. But in this case, he says don't use intramuscular because there are two reasons. One, if it is a viper bite, you inject into the muscle, it will cause a hematoma. Second, the BP is too less, so absorption may not occur because the BP is already less because of the snake bite, plus the anaphylactic shock will cause further crashing of the BP. So absorption can be erratic. So this is one situation in anaphylactic shock where he has mentioned IV adrenaline to be given to the patient. I would like to clarify this statement once again. If a question simply says, what is management of anaphylactic shock? First line management is intramuscular adrenaline. That is undiluted format, and anaphylaxis I have handled separately, so you can listen to that section. But in case of a ASV, because of the high incidence of allergic reactions severe enough to cause anaphylactic shock, he mentions that keep adrenaline ready in a syringe attached to a three-way stopcock, and you can just inject it via the three-way into the main line and flush it with saline subsequently so that it reaches up to the target organs and thereby reduces the laryngeal edema component of the patient.